invite the first four speakers for the next paper session 3. Come on up, and then our moderator for the session is Dr. Ashraf Naga. Dr. Naga is the director of the spine service at San Francisco General Hospital. So thank you so much.
All right, well, we have a couple exciting talks, and we'll make up a little bit of time, so we'll get straight to it. And I invite Dr. Mott to present his paper. Can we have the PowerPoint up? Characterization of ion release from a novel biomaterial, molybdenum 47.5 rhenium in physiologic environments.
Thanks. This is really exciting stuff. I have relevant disclosures. I receive royalties and consulting income from Mirus, which has exclusive rights to molybdenum rhenium. So technology has driven spine surgery forward. It's come a long way since I was a resident 20 years ago. And these advances have come mainly in technique and implants. So minimally invasive surgery, navigation, robots, endoscopic spine surgery, 3D printed implants, percutaneous screws, and expandable cages. But there are still great unmet needs in spine surgery like rod breakage, and this is because of limitations of the material. In other words, we're still constrained by the material properties of our incumbent metals, and they are stainless steel, cobalt chrome, and titanium. Now, stainless steel has kind of fallen out of favor in spine surgery because of problems like corrosion, but cobalt chrome and titanium make up most of the spine implants that are on the market today. Now, we say cobalt chrome and titanium, but actually they're made up of many different elements, and these impurities can lead to reduced fatigue life, tissue reactions, and allergic reactions, as well as metallic ion release. So I'm going to be talking about a novel biomaterial called molybdenum rhenium, or MORE. This is the first new biomaterial approved by the FDA in 3 decades. And MORE is special because of a couple things. The first is that it's very pure. It's made up of only 2 elements, molybdenum and rhenium. And it also has these very good biomechanical properties. It has a stiffness and yield strength 2 to 3 times more than titanium and cobalt chrome. It has great fatigability, meaning that it doesn't break over time, and also notch sensitivity, meaning that it doesn't break even when it's notched. But as with any new technology, the first question we ask is this stuff safe? So in order to answer that question, we evaluated the ion release profile for MORE and compared it to cobalt chrome and titanium. So we took rods made of MORE, titanium, and cobalt chrome. These are made in accordance with ASTM guidelines for medical implants. And for the MORE rods, we did a prolonged immersion test and then measured the amount of ions being released over 30 days with mass spectroscopy. In the second scenario, we did a highly inflammatory environment with hydrogen peroxide and then compared the ion release of MORE with cobalt chrome and titanium. So the results are going to be expressed as micrograms per surface area per day. And then for the total exposure, we used the assumption of 100 centimeters square of surface area. So this is something, what you might envision, but actually the reality is much more mundane. If you're wondering what those white plastic balls are, they are white plastic balls to prevent the heat from escaping. We maintain an environment at 37 degrees with a solution that mimics interstitial fluid with low oxygen, and we sample it over 30 days. And this is in accordance with the ASTM guidelines for corrosion susceptibility of implant devices. The second situation is the hydrogen peroxide challenge, and we used a concentration 1,000 times physiologic levels and then sampled for the 8 days. So this is what the results look like. The x-axis is going to be number of days. The y-axis is the release micrograms per square centimeter per day. And in the physiologic condition for both metals, molybdenum and rhenium, the release levels are very low. At steady state, they're in the nanogram range. And with the hydrogen peroxide challenge, it does go up to a peak of 0.32 and 0.37 for molybdenum, rhenium, respectively. But by day 8, it's starting to return to its steady state. But really, to give this clinical context, you need to know what the permitted daily exposure is. So this is stuff that's published by the ICH in Europe, the FDA in the United States. And after you finish looking at Mr. Yuck there, I want you to pay attention to this column here, which is the permitted daily exposure. Now, you notice that for aluminum and titanium, there are no numbers published because you could actually eat this stuff. We eat about 9 milligrams of aluminum per day in our pop cans and our hamburger wrappers. And titanium is actually an ingredient in Skittles, which is another reason why not shouldn't eat that stuff. But if you look at cobalt and vanadium, you could see that the PDEs are a lot lower than the other elements, and this becomes relevant later on. So when we express the same results that I showed earlier in terms of percent PDE, you can see that at most it's 1.28%, but at steady state it's 0.02% for millennium and less than 0.01% for rhenium. And even with the hydrogen peroxide challenge, it goes up, but it's still 1.7% and 0.84%. And by day 8, it's reduced to 0.06% and 0.02%. So it's very low PDE. Now, in contrast to that, when we do the hydrogen peroxide challenge on cobalt chrome, for cobalt, you can see that it peaks at 914% of PDE. So that's not good. And by day 4, it's come down, but still 168% more than your permitted daily exposure. Chromium's not bad. And millennium, interestingly, this is very similar to the results from Moore, even though millennium's only 6% of cobalt chrome and it's 53% of Moore. For titanium, the only thing we really care about is the vanadium. The vanadium PD is highest at day 1, 47%, and by day 4, it goes down to 25%. So taken together, metal ions is an issue that as orthopedists we're familiar with because of the experience with metal-on-metal arthroplasty, but it's also relevant to spine surgeons. The literature has shown for all of the incumbent metals, there are elevated levels of metal ions in patients' blood after spinal fusion. But it's also important for me to say that the clinical significance of this remains unknown. What we showed today was that Moore has low metal ion releases in both physiologic and inflammatory environments in terms of percent PDE, whereas when you compare it to cobalt, chrome, and titanium, they have ion release levels that approach PDE or even exceed it. So in conclusion, even though we don't know the clinical significance of these metals are not good for you. In vitro testing has shown them to be toxic. And when you think about our patients being exposed to this long-term, especially our AS patients, many of whom are young females of childbearing age who have their whole life ahead of them and might get pregnant, well, when you consider the metal ion release profile as well as the biomechanical advantages of Moore, it might represent a valuable alternative to the current incumbent metals for spinal fusion. Thank you very much.
Next, I'd like to invite Dr. Anna Feely to present the influence of bone health on the risk of mechanical complications after lumbar spine fusions for degenerative disease, a systematic review.
Hi, good morning, everyone. My name's Anna Feely, and today I'll be talking about osteoporosis as a risk factor for mechanical complications after lumbar fusion. I have no relevant or not relevant disclosures. So first, a bit of background information. In terms of scope, osteoporosis is a really common comorbidity in patients with degenerative spinal disease, with one large retrospective study showing that about 80% of patients presenting for spine surgery had underlying osteoporosis or low bone mass. This is important because there have been a number of studies that have shown or correlated low bone mass with poor outcomes in mechanical complications after lumbar fusion. But more importantly, there's something we can do about it. So a preoperative diagnosis of osteoporosis allows for targeted intervention in the form of modifying the surgical strategy or medically treating these patients to hopefully mitigate complication risk. Currently, the gold standard for obtaining information about bone density is with DEXA T-scores, but there are a number of other ways to get information about bone density or quality. But ultimately, this just isn't a routine component of the preoperative evaluation, and this is for probably a lot of reasons. Some related to feasibility, so cost, access to DEXA, the current gold standard, accuracy concerns for accuracy of lumbar T-scores in patients with degenerative disease, and then just an overarching knowledge of the impact of low bone density on surgical complications, and then finally a consensus with who should we be screening and what are we going to do with this information. So to better address all of that, our team aimed to better characterize the influence of osteoporosis on specific mechanical complications of lumbar fusion surgery. To do this, we did a systematic review focusing on studies that looked at bone health or osteoporosis as a primary predictor of specific mechanical complications after instrumented lumbar fusion for degenerative disease. And what we found, so there were 71 articles included, and something that I'd like to point out that in that little book there in the abstract that I initially submitted last year, there were 58 studies. And so in the subsequent months, that number has gone up significantly. A third of those 71 studies were published essentially within the last year. And I think that really highlights how now's a great time to pause, take a step back, and take stock of what we do know in order to better inform how to move forward as a community. So of those 71 studies, there were 38 that used DEXA, the current gold standard, to screen for osteoporosis. 42 looked at other diagnostic modalities, most commonly Hounsfield units, and then 9 had data from both for comparison. So, and something else to quickly note, of the 38 that had a DEXA for their entire cohort, the locations of those measurements varied widely and were inconsistently reported. So there were 6 primary outcomes we looked at, and then in the interest of time, I'm just gonna touch on 2. Cage subsidence and screw loosening were among the most common complications looked at as a function of bone density. The procedures that these patients underwent in these studies varied pretty significantly, as did the diagnostic criteria for identifying complications. So including the imaging study used, the timing of these radiographic assessments, and then the criteria or thresholds to identify cases. So not surprisingly, the reported complication rates varied pretty significantly, but in terms of risk factors, poor bone health was identified as a contributor to these complications in 21 of 24 studies looking at cage subsidence and all of the ones looking at screw loosening. And then in particular, measurements made at the end plates and screw trajectory were found to be particularly predictive of these 2 complications. Then some just overarching observations across the whole study. Number 1, the body of literature is characterized by significant heterogeneity, which I think is really important to note first and foremost, because our results have to be interpreted in the context of these limitations, and this also functionally precluded a relevant meta-analysis. Then second, among those 9 studies with enough data to compare multiple modalities, pretty much all of them showed that alternative metrics were more predictive of complication risk than traditional DEXA T-scores. And then off of that, there were unique site-specific measurements that were shown to have particular utility in predicting specific complications. So like the screw trajectory and the end plate metrics, as well as bone density measured like at the UIB or adjacent levels to predict PJK. So what can we take away from all this? The first major conclusion is based on what we do know. And based on our review, there's enough evidence right now to suggest that osteoporosis is an important risk factor for mechanical complications. But what we don't know is really the best way to characterize this risk and what its magnitude and implications actually are. So in terms of the diagnostic study that should be used, who should be screened, where those measurements should be taken, and then what thresholds best predict or best identify at-risk patients. And then if all of that should vary based on the surgery we're doing or based on the complication we're looking at. And then finally, kind of where do we go from here and what's still necessary? And that's further study using standardized methods to confirm these findings, and then also to ultimately determine best clinical practices for screening and perioperative optimization that can afford for better patient care. Thank you.
Thank you so much. Now I'd like to invite Dr. Ryan Halverson to present on multi-domain biopsychosocial postoperative recovery trajectories associated with patient outcomes following lumbar fusion.
Fantastic. Thank you, Dr. Naga. So today I'll be talking about what we're calling biopsychosocial recovery after lumbar fusion. Even if you don't do spine surgery, the methods I'm going to talk about today are applicable to other patient populations as well, and I think are changing the way that we're thinking about and approaching patient outcomes. So our disclosures are listed in the bulletin. So who are these two people? So Susan Folkman was a graduate student at Berkeley in the late 70s, early 80s, and then actually became the director of the Osher Center here at UCSF. And the reason, and this was her mentor, Richard Lazarus, and the reason I bring this up is because they actually revolutionized in terms of psychology how we think about how people respond to stresses in the environment. And so their idea was that as people, we perceive different stresses, whatever that may be, and then appraise that cognitively. How do we respond to this? Is this a threat? And then reappraise that in our minds. Is this something that we need to change our behavior, change our mental approach to dealing with? And the reason I mention this is because one stressor that we deal with all the time is low back pain. And how low back pain affects patients goes beyond objective findings like weakness and pain. It actually impacts how patients function day to day. It impacts how they perceive their mental health, their physical health, and effects on how they interact with others in society and their role. And so what we know is that over time, after surgery and even before surgery, all of these factors are interrelated and change. And it's dynamic. They all affect one another. And we don't actually understand very well how these factors play together. And we don't have very good quantitative methods to look at this. And so we don't have very good methods to do this, but why should you care? Well, aside from patient counseling, this is an opportunity to provide personalized care. What if we could tell one patient that they may be at risk for a longer recovery and someone else that they may recover more quickly? More and more PROs are being used as part of regulatory reporting, quality improvement, used in research across both industry and academia, and then also with insurance. And so our overall idea was, can we identify characteristic patterns of recovery following surgery? And so the purpose of this study was to try to quantify what we called biopsychosocial recovery following lumbar fusion. And then we wanted to assess the relationship between identified recovery patterns or phenotypes with pre- and post-operative clinical outcomes. And our hypothesis is that we'd be able to identify discrete patterns of recovery that would associate with preoperative factors as well as post-operative outcomes. And so in terms of methodology, we identified patients undergoing lumbar fusion. And then we followed them for a year and recorded a number of parameters, including pain, disability, but also a set of what we called biopsychosocial variables, which included anxiety, depression, how patients perceive their own role within society, and other things like fatigue. And so we tracked these for 1 year. For most patients, this was recorded at around baseline, 3 months and 1 year, but some patients had more data than this. And the timing is a little bit inconsistent. And so you'll see that time is modeled as a continuous variable in this study. So we generated several models, which are latent process models, which allow us to assess for patterns of recovery using this data. And so the first model we generated was using just pain alone. So can we cluster patients? Are there distinct patterns in how patients recover if we just look at how much pain they experience? And then we created a second model where we looked at both pain and patient disability. And then a third model, which is what we're calling the full biopsychosocial model, which includes data from each of these factors. We then took basic demographic information as well as surgical information, including the number of levels fused approach, the region of the spine, operative time, and preoperative opioid use. We assessed associations between preoperative factors and recovery phenotypes using univariable models, and then included significant factors into a multivariable multinomial regression, which allows us to predict the patient recovery phenotype from preoperative data. And then we assessed associations with postoperative outcomes, including length of stay, opioid use, ED visits, and readmissions, using multivariable regressions controlling for baseline factors. So this is our cohort. So we had 709 patients, of whom 510 were included. The average age was 65, about half were female, and there were a variety of levels fused. Each of these lines on the right of the screen represents patient recovery in a specific domain over time, over the first year. And so on each of the y-axis, you'll see that the worse symptoms are higher numbers, and so over time, the lines get lower. That means patients are getting better. And so we talked about those three models that were generated, the first using pain alone. So we looked at patient pain over 1 year, tried to cluster patients, and so this graph here represents a fully optimized model where the y-axis represents something called a latent process variable. And so the pain scores are mapped onto this latent variable, which is then used to create clusters or patterns or phenotypes of recovery. And what we found is that if you look at just pain alone, you can't actually identify very meaningful clusters. Most patients tend to improve. And so you see is that one class includes almost 90% of patients. So it's not really giving us much more useful information than we already know. We created a second model then using both pain and disability. And this was actually even worse. So now 98% of patients have improvement in pain and disability, which is not very useful overall. But finally, in our final model, using pain, disability, and then that full set of biopsychosocial parameters, we actually start to see some meaningful information, which I'll go through on the next slide. So of the 510 patients, 11%, you'll see in blue, are what we call gradual responders. And so these are patients I'll get into on the next slide. But again, on the y-axis, this latent variable represents like higher numbers are worse recovery, lower numbers are better. So as time goes on, most groups are getting better. And each variable, each dot on this line represents a composite score of each of those variables together. In red, we have a group of what we call rapid responders, and then in green, rebound responders. And so gradual responders actually started with more mild symptoms, lower on the y-axis. Rapid responders, about a third of our cohort, had actually the worst symptoms at baseline and improved the most. And then rebound responders, which is about half of our patient population, had overall a net improvement, but had some sort of return back towards their symptoms at the end of the 1-year study period. Looking at the associations with preoperative outcomes, we use the gradual responders as the reference for our model. Rapid responders are more likely to be male, have fewer levels fused, and then use preoperative opioids. Rebound responders were more likely to use preoperative opioids. I'll touch on that in a moment. No differences were observed in race, ethnicity, any other demographic factors, ASA class, approach, or operative time. Looking at postoperative outcomes, there were no differences in 30-day ED visits or readmissions. Rapid responders, interestingly, had the longest length of stay and the most opioid medication used postoperatively. And if you'll remember, these are the patients who came in with the worst symptoms. So 3 recovery phenotypes were identified from the biopsychosocial model. These were related to preoperative opioid use, sex, and the number of levels fused. Postoperatively, this was related to hospital length of stay and also postoperative opioid use. So limitations, it's challenging to identify what the true number of phenotypes or patterns actually is. There may be additional phenotypes that were not identified due to power in this study. Preoperative opioid use was also included as a binary variable because our information commons doesn't actually have the quantity or frequency or duration of preoperative opioid use available. And so I think that might help tease out why that was a predictor for 2 of the groups. We don't have follow-up beyond 1 year for longer-term revisions, and this is a single institutional study. So in conclusion, this concept of multi-domain longitudinal phenotyping I think is a novel and pragmatic tool for studying patient outcomes in orthopedic surgery overall. In this case, with lumbar fusion patients, it was difficult to identify meaningful patterns using just pain or pain and disability without using all of the full biopsychosocial factors. And so these things are critical in looking at these patients that should be included in future studies. And we hope that this will help give us a better understanding of how patients experience pain and respond to our interventions. Thank you.
Very fascinating. Next, I invite Dr. Adriana Baldwin to present on the effects of social determinants of health on preoperative presentation of patients who underwent operative management of degenerative spondylolisthesis.
Ryan's so tall. Hello, good morning, everyone. Happy to be part of this great panel discussions today. So I'm excited to present the work that myself and my co-authors have been working on, looking at the effects of social determinants of health on preoperative presentation of patients who underwent operative management of degenerative spondylolisthesis. I do not have any disclosures. So the central question of our current work is to focus on how social determinants of health, which I will define and describe next, affect the clinical presentation of this operative spine population, with the purpose of understanding the factors that influence a patient's access to surgical care. So basically, who gets surgery and how do they present? So we must first understand the social determinants of health are. In summary, they are a compilation of conditions in one's environment that encompasses many factors, such as where they live, work, play, and have community. They are going beyond the pathophysiology we learned about in medical school, akin to Dr. Halverson's biopsychosocial model. They also expand beyond the traditional values of race, gender, and socioeconomic status that are historically used. In the medical field, we know that these social determinants of health affects access to general medical care. For instance, we know that this compilation of conditions affects decreased access to primary care physicians. And the current orthopedic works that we currently look at tend to focus on post-operative outcome data. And so this chart is a visual representation of the complexity of the various components of social determinants of health. We've done our best to categorize each data measurement into a group, but this shows you it's more than just one variable at play here. And the population that we chose to look at this issue of access to care are patients with degenerative spondylolisthesis. This is the forward slippage of the vertebral body due to degenerative changes of the spine. This is one of the most common causes of back pain and disability. And while there are a variety of treatment options, there is data that supports the operative treatment of symptomatic patients. So we can make these patients better with surgery, and so we have to also know who they are. And again, so this was a single retrospective review. We used the electronic medical record to look for variables that will serve as proxies for these data points here. So, for instance, we found variables in the EMR such as employment, marital status, insurance, et cetera. So we were able to hopefully, our goal was to encompass all of these different points to make sure that we were capturing all aspects of social determinants of health. Zip codes were collected from the medical record, and they were used to link patients to US Census tracts. The distance traveled was mapped using the shortest driving distance from the patient's listed home address to spine clinic, and the patient income was estimated using median income census data from the zip code. And then we also collected baseline demographics. I will note that some of these variables we were unable to touch upon due to the limited access within our system, in the single system. For instance, when you look at language, there were not enough patients that we found within our data set that had a variety of language for us to actually do data on. So that's another note within this work. And so for the outcomes, we then looked at the time from referral to surgical consultation, as well as the symptoms that they had at this initial visit. And so overall, we found that of the 184 patients that we were able to have complete data for, that the following were statistically significant. Lower income was associated with longer and worse symptoms at that initial visit, as well as a longer duration to pending to their initial referral. We also found that greater distance from the center was associated with longer duration of symptoms and longer duration of referral. So patients who were further away from the center had to wait longer and also presented worse. And then also public insurance was associated with a longer time to first consultation. And so overall, the past work and this current work are showing that there are many components of social determinants of health, such as in this study, lower income, public insurance, and distance from center that negatively affect the clinical presentation of patients with these operative conditions, and that these patients have a greater difficulty accessing care. And so while this work is certainly important, it is not without its limitations. So the first is as I noted too about language, is the importance of the granularity of this data. So this is not something that is easily or honestly can be done from these large data sets that we currently have produced, because the details are not there. This is data that needs to be collected through looking through a chart, seeing what is noted in the visit and things that are commented on to make sure we're encompassing the entire aspect of care. And so that makes it, and especially in a single center study, it makes it difficult when you do not necessarily have that diversity of patients. Also, when we look at social determinants of health, we evaluated them using these individual components. We haven't been able yet to do a composite score to see actually how are these different conditions at play, and is it these individual components, or is there more complexity, which I would allude to there is more complexity at play here. And then also the purpose of this work was to look at access to surgical care. So people are missing, right? How do I capture those people who have symptomatic operative conditions that are not yet at our center? And so, we want to also understand those patients too. So I would say for future directions, the good news is that there is increased interest in this field, and with that, and the age of innovation, there are steps to make this work a little bit more accessible. And so there is actually currently applying this natural language process center here at UCSF in order to use that technology to filter through notes themselves. So it's not a one-person or a three-person job of trying to look through each chart and sift through all these things. So if we can program something that says, look for these keywords, and then it can actually then give us the results, and maybe there's data that we're missing that we can also look at there. And so that's very exciting. And then, like I mentioned before, the creation of a composite score to make sure we're actually understanding the complexity. And so with that, that's basically where we are now. I'm really hopeful for where this work and where it can be going. And thank you again to all my co-authors here.
Thank you all for all these thought-provoking presentations. We have a few minutes for questions, and I welcome members of the audience to come up to the microphone. But I'll start off actually with a question for Dr. Baldwin. So in your presentation, you highlight the effects of the social determinants of health on access to care, and we're looking at sort of the effect on the patient side. But what are some things that we can do either from the provider side or as a state institution to mitigate the effects of this disparate access?
Hi. Yeah, so I think that's part of the honestly, my frustration with this work. I feel like we're doing these things, we're identifying these risk factors, but also at the same time, I feel like we could be working in parallel. Like, what can we be doing now as an institution to gather to actually find these patients instead of just saying these are the rattling off what are the risk factors. And so some of the things that I've just been thinking about, and also that have been done within other fields, including surgical fields, is opening up telemedicine. And I think COVID has really shown us the ability of us as orthopedic surgeons, even though we need the physical exam, to use telemedicine. There's been recent work validating series of exams that you can have patients do. I think also using patient care navigators, so going through referrals and seeing what are at risk. And so maybe that's how the work that I'm doing now can help influence. So the patient care navigators knows that patients from these groups are at risk of having longer duration. So they flag those charts and they reach out to the patient, or they reach out to patients that are from a certain distance, and maybe those patients are offered a telemedicine visit. And so they can then gather all the images that they need. And then their first visit isn't a visit where we say, hi, can't help you, please come back with imaging. So I think those are just and then the third way I've also been thinking about is how do we partner with PCPs, and what PCPs do we partner with? I do think there are a lot of ways in which certain UCSF providers have easy access to orthopedic surgeons, but I'm not sure about the community. And so what can we be done there?
Hi, this question is for Ryan Halverson. Yeah, really fascinating work, this multi-domain trajectories here, and identifying the three different cohorts that you were able to identify. My question is, at the conclusion, you talked about the number of levels being important in the outcome. I was wondering, was that a part of your modeling, or is it something that you think could be altered? The plan is altered by understanding this multi-dimensional system. I didn't quite understand that. Yeah. Because, presumably if the patient has two levels of problems and you're going to do a two-level surgery, or one level problem, you're going to do a one-level surgery. That's not probably something that we could modify.
Yeah, that's a good question, and kind of gets at like what is a modifiable and non-modifiable risk factor that might bump you from one trajectory to another trajectory. In this case, the trajectory modeling was performed just on the patient outcome scores, and then those preoperative and operative factors were used as predictors of those trajectories in the separate model afterwards. So this is a couple of limitations. It's a retrospective study, and so we weren't able to assess like what the imaging was, what the imaging findings were, and assessed like the appropriateness of a particular intervention based on that. I think that would be a potential area to look at in future studies, is actually look at the imaging data. And then there might be cases where trying to decide on the extent of the construct, we might be able to include some of this work in that decision-making process. But that is retrospective, and so that was used as a predictor of the trajectories. And so right now we just know that there's an association.
Yeah, thanks. Aviana, you mentioned what I'm going to ask about, but I'll direct it to anybody for whom this is relevant. There's a lot of excitement around artificial intelligence, natural language processing. We use those terms, and it's kind of dependent upon having the technology and whether the database you're using is searchable in some way. I'm just wondering how many of you are actually using now advanced information processing, and is it accelerating your research at this point in time?
Well, I am hoping it will be. Actually, Anna and I are in talks with some of the researchers here in order to help utilize that within our work to see if it is faster. Because it's, to be quite honest, it's cumbersome work going through each chart. It's not as simple as putting a code in for it. And so I'm hoping it does, and it makes this a little bit more, it can be a little bit more bigger database work.
Yeah, actually UCSF banned ChatGPT last week. I don't know if you all saw that email. It sounds like they're planning to unban it at some point in the fall, but right now it is currently against the rules to use it. There are other language models, like C-Takes is one that the NIH has put together, which I'm looking at for some other work. But you can't just like download the charts as it stands and then just feed that into ChatGPT. Although I assume there will be some ability to do that probably in the fall. But right now the technology is ahead of UCSF's policy.
Yeah, no surprise there. Okay, thank you.
Question for James. This material is really interesting. It's also MRI compatible, and you can, it's not ferromagnetic, so you can get MRIs around it, and you can image soft tissues. The question I have is really, do you have any idea what those small amounts, even very microgram amounts, do to osteocytes? Because we're putting it close to a fusion bed and maybe to the nerve, because they're different ions, right? And although systemically it may not be toxic, locally it could exert effects. The other follow-up question is, when you did your studies, did you use similar surface area implants like the rods? And because the beauty of that particular metal is that you can use a smaller rod and then finally fretting corrosion. You have oxidative corrosion in the solution, but what happens when you put it on the surface and something's rubbing or potentially creating a stress or etching of the material?
Yeah, thanks for involving me, Dr. Tay. Yeah, so it looks like you have some familiarity with the, actually I got involved with it because I like to do minimally invasive spine surgery, and they have a 4.5 millimeter rod, and it's mechanically equivalent to cobalt chrome titanium with a larger diameter. So in response to your first question, which is kind of related to your third about the amount of corrosion of local soft tissues from rather than chemical stress, but mechanical stress. So more is a very hard material. In fact, it's very hard to grip, with like a pair of pliers and stuff. And so that mitigates the amount of ions that are produced from mechanical wear, which is a big concern, especially in our really big fusions where you have all these connections between screws and rods that are a lot more than Harrington rods, which is what most of the metal ion data is based off of. So it's an area of concern, especially cobalt chrome, but with more that's mitigated because of the characteristics. And we do have in vivo data on that. And then in response to, these ions are different, how are they going to affect the tissues differently? I don't have a good answer other than to say that less of these ions are being produced. And finally, another benefit of this is hydrophilic, more so than even titanium. And so we think that might also help with being appropriate for fusion. Hope that answers your question.
Thank you all for the discussion.
We'll move over to the second session, and I'd like to introduce Dr. Saeed Ali, who's going to present on the cost effectiveness of intramedullary nailing versus external fixation for the treatment of open tibia fractures in Tanzania.
Good morning, everyone. Thanks for the opportunity to present our research. So I have no disclosures. So some background. So historically, orthopedics has been less popular in global health as compared to other fields. And this is mostly due to perceptions of low cost effectiveness. Recent studies have shown that surgical interventions may actually have similar cost effectiveness to more popular global health interventions. But the orthopedic literature currently uses US-based data. For global orthopedics, it's very important to consider indirect costs and benefits and not just the direct costs. Orthopedic trauma procedures may have high upfront or direct costs, but also carry significant indirect benefits, such as, for example, a functioning, properly aligned limb over a 60-year lifespan. You can imagine this would have a big economic impact in societies where the majority of the population performs manual labor or subsistence farming. So open tibia fractures specifically are a significant cause of morbidity in developing countries and have very high rates of complications in these settings. These complications often necessitate further intervention, such as reoperations or even amputation. As you can imagine, there is a substantial economic impact of these injuries on both the patients and the healthcare system. Africa specifically has the highest road trauma burden in the world. And unfortunately, up to a quarter of patients in these settings do not return to work 1 year after injury. So operative treatment in low resource settings is generally in the form of external fixation or intramedullary nailing, whether by the sign nail or other intramedullary implants. Current meta-analyses that look at these treatments in high income settings favor intramedullary nailing due to a variety of factors, but especially lower rates of malunion and reoperation. Unfortunately, adoption of nailing in low resource settings remains low because of perceived high upfront costs, which limits investment. If you solely look at implant costs and ignore factors that contribute to the total economic cost of treatment, such as we were discussing, lost productivity or slower return to work, you may not be choosing the most cost-effective intervention in these settings. This led to our research question: what is the cost-effectiveness of intramedullary nailing as compared to external fixation when used for the treatment of open tibial shaft fractures in resource-limited settings, specifically our setting in sub-Saharan Africa? So moving on to methods. So this was a planned secondary analysis of data from a prior randomized trial. It looked at intramedullary nailing versus external fixation at a single tertiary center in Dar es Salaam, Tanzania. Our inclusion criteria are listed up there, but briefly, we enrolled adults with open tibia fractures. They were randomized to treatment with intramedullary nailing or external fixation. Patients followed up at standard intervals for 1 year and also had a longer-term follow-up visit at 3 to 5 years, where outcomes were assessed, including quality of life. Inputs to our cost-effectiveness analysis included costs, utilities, and probabilities. Direct costs included the costs of all involved personnel using time and motion analysis, along with the cost of medical and operative supplies, medications, the surgical implants themselves, and the cost of reoperation. Indirect costs included lost productivity of patients prior to return to work. The utility of each outcome was calculated from health-related quality of life as we assessed by our EQ5D score. And then finally, from our outcomes data, we generated probabilities through which we created a Markov model, shown here, to compare cost effectiveness of both interventions. We then assessed incremental cost effectiveness ratios over a lifetime time horizon for both. So moving on to our results, patient demographics for the study cohort are shown in Table 1. There were no significant differences. And then, Table 1. Figure 1 shows quality of life over time for both interventions. And as you can see, there is an important trend towards higher quality of life at early time points for patients treated with intramedullary nailing. There is also earlier return to work for intramedullary nailing patients. Tables 2 and 3 break down costs and utilities for each modality. Operative costs for intramedullary nailing were higher, not actually due to the implants themselves, interestingly, but due to longer OR time. That was the main reason. Utility at 1 year, and indirect costs were much lower, as you can see in terms of lost productivity. Utility at 1 year was equivalent, but intramedullary nailing patients, as we said before, tended to have a faster recovery in quality of life and also return to work sooner. Over a lifetime, we calculated an incremental cost effectiveness ratio about $500 per quality for nailing from the payer perspective. That is, to analogize, it would cost $500 to provide patients 1 additional year of full health. When you consider all indirect costs using a societal perspective, the ICER is even lower. We next performed linear and Monte Carlo sensitivity analyses of our data and compared it to WHO criteria for cost-effective interventions, which is based on the GDP of the host country. Using the Monte Carlo simulation, 60% of the models we ran favored nailing as a highly cost-effective intervention using the WHO criteria and Tanzanian GDP. So moving on to our discussion. So from this data, intramedullary nailing appears to be a highly cost-effective intervention using WHO criteria when compared to external fixation. At the societal level, it may even approach cost savings, given the faster return to work and higher quality of life. We believe that the preference of the model for nailing stems from this earlier return to work and the higher quality of life data. And we think that further investment and training in nailing should be considered in these low-resource settings. And here's some references, and thank you for your time.
Invite Dr. Kelechi Iwachukwu to present on intramedullary K-wires versus titanium elastic nails for pediatric femur fractures. No difference in modified REST scores in a randomized clinical trial in Darcy.
Hey, good morning, everybody. Thank you so much for this opportunity. My name is Kelechi Iwachukwu. Happy to be here. So I will be presenting on a randomized clinical trial comparing intramedullary Kirschner wires to titanium elastic nails for pediatric femur fractures in Dar es Salaam, Tanzania. Okay. And our study has received financial support from grants from the OREF and Foundation for Orthopedic Trauma. We have no other relevant financial disclosures. The devices used within the study have received approval for the use by the Tanzania FDA. So looking at the background of the study, trauma is the leading cause of death and disability in children. Moreover, as displayed here, it disproportionately affects those in developing countries. Among injuries in children, femur fractures are among the most common injuries that lead to disability, requiring the attention of orthopedists. In addition, children in low and middle income countries are twice as likely to sustain femur fractures compared to children in high income countries, in part due to population demographics and less road safety infrastructure. As far as the treatment of femur fractures, this varies by age and fracture pattern. In the mid-child age group, this is commonly treated with flexible intramedullary nails. Previously, our group found out that there was a significant trend towards non-operative treatment of these injuries in low and middle income countries. However, this wasn't based on evidence. Rather, this was due to limited implant availability and cost, unfortunately. Recently, the use of intramedullary K-wire fixation has emerged as a low-cost alternative for fixation of pediatric femoral shaft fractures. This technique applies the same principles as fixation with elastic nails while using commonly available and affordable implants. There have been several retrospective case series demonstrating good outcomes with this technique. In fact, our very own Dr. Diab champions this fixation method in his own patients. Prior to expanding this technique more broadly, however, it's important to assess whether locally available K-wires are equivalent to elastic nails in a resource-limited setting. Therefore, the purpose of this study is to perform a randomized clinical trial to compare the intramedullary titanium elastic nail to K-wire fixation for diaphyseal femur fractures in pediatric patients at a tertiary care facility in Tanzania. Kaiser and Beatty criteria were used to define radiographic malunion based on age group, taking into account varus valgus angulation and anterior-posterior angulation. However, because clinical rather than radiographic shortening was assessed, our methods for assessing malunion excluded shortening. Secondary outcomes included modified RUS score, PEDS QL questionnaire, squat depth, and clinically assessed complications. Inclusion criteria were children aged 5 to 14 with acute femoral shaft fractures who were able to return for routine post-op visits. Exclusion criteria included injury older than 14 days, skeletal maturity, weight greater than 50 kilograms, among the others listed here. The study timeline spanned over a year, beginning with the patient's initial presentation to the center, where they underwent radiographic and clinical screening. After this, they were consented for the procedure and study, underwent the procedure, followed by interval follow-up for a year with various data points collected at each visit. In terms of patient population, 61 children between ages 5 to 14 with acute diaphyseal femur fractures were randomly assigned to intramedullary K-wire or elastic nail using a 1-to-1 allocation module. Of all these patients, 83% completed 1-year follow-up. On average, the K-wire group was 1.3 years younger than the elastic nail group. Of patients who sustained a fall as a mechanism of injury, fewer patients in the K-wire group sustained a fall from standing height. But otherwise, treatment groups were similar with respect to demographics, injury, characteristics, and perioperative details. Radiographs were reviewed by 2 masked surgeons with a 3rd surgeon available for consensus following differences between raters. To note, the surgeons were all fellowship trained. As far as results, we found similar rates of union between study groups at each measured time, with most completely united with evidence of remodeling at 6 months. There was no significant difference between K-wire and elastic nail and radiographic malunion at final follow-up, according to the Kaiser and Beatty criteria. The modified RUS scores were assigned according to the criteria set by Latrenta et al., where each cortex was scored from 1 to 4, with 1 being callous, 2 being callous, with 1 being no callus, 2 being callus present, 3 being bridging callus, and 4 remodeled with no visible fracture, yielding a score ranging from 4 to 16. There was found to be no significant difference between the 2 groups at any time point, with K-wire group in the end having a score of about 15.52 and with elastic nailing having 16. There was also no statistical difference for any time point in both sagittal and coronal angulation. Another secondary outcome was a squat and smile score, which is a verified assessment score, which was pioneered by our very own Hawa Wu. And this was also assessed. It entails asking patients to squat as deep as they can comfortably tolerate without assistance, and smile with a minimum score of 4 and maximum of 12. We found increasing scores from 6 weeks to 1 year without any significant difference between elastic and K-wires, elastic nails and K-wires. The PEDS QL was used as an additional assessment for functional scores. The PEDS QL has several domains, including physical function, emotional functioning, social functioning, and school functioning. There was no significant difference found between the 2 groups. Finally, at the time of final follow-up, there are 3 complications in the K-wire group and none in the titanium elastic nail group. However, the difference of complication rate had a one-sided Fisher exact p-value of 0.145, suggesting an insignificant difference. So in conclusion, our study reveals that intramedullary K-wires have similar outcomes to titanium elastic nails for pediatric femur fractures in a low resource setting when considering fracture non-union, quality of life, and squat depth. Because similar outcomes may be achieved at much lower cost, these implants may allow for increased access to surgical care and ultimately reduce the global burden of pediatric femoral shaft fractures. Thank you for your time. I would like to acknowledge our study team and our grant support through ORIF and then the Foundation for Orthopedic Trauma.
Thank you so much. Factors associated with hardware removal and fascial ankle fractures, analysis of the pediatric health information system.
Awesome. Thank you so much for having me here today. I'm Kaz. I'm one of the third-year residents here at UCSF, and I'm going to be presenting this project here today. I have no disclosures. So fascial fractures are common injuries in the pediatric patient and make up 20 to 30% of fractures in children overall. In particular, fascial ankle fractures account for between 1 in 5 and 1 in 10 of all fascial injuries in children. The goal of treatment in fascial ankle fractures is anatomic reduction of the physis in order to preserve growth. Close reduction is part of the initial treatment algorithm for displaced fractures, and operative management becomes warranted for unstable fractures or displaced intra-articular fractures. Operative management typically consists of either CRPP or ORIF. In terms of removal of hardware, it has been reported that nearly 20% of hardware is removed in pediatric tibia and fibula fractures, although this was not isolated specifically to the physis nor specifically to the ankle. The indication for hardware removal includes pain, mechanical dysfunction, infection, and patient preferences, among other reasons. Overall, there's a lack of consensus regarding the last point, removal of asymptomatic hardware, which is often driven by the patient and the family. The purpose of the study was to determine the rates and factors associated with hardware removal in pediatric fascial ankle fractures, as well as the need for subsequent ankle surgery in order to provide more information to providers and patients to help augment decision-making. In this study, we utilized the Pediatric Health Information Systems database, which includes inpatient, emergency department, and ambulatory surgery encounters. This database has the advantage of including ambulatory surgery centers, given many of these procedures are outpatient procedures, whereas other pediatric databases only include inpatient encounters. Another strength of this database is that it includes a broad swath of pediatric hospitals across the country. Finally, the database allows for the ability to longitudinally follow patients by de-identifying their data, assigning ID numbers, so that all surgeries that individual patients have can be tracked over time. The database uses ICD-10 procedure and diagnosis codes. The main cohort included patients who had surgery from 2015 to 2019, which allowed for 2 years of follow-up, given patient data was collected through 2021 at the time of analysis. The transition from ICD-9 to ICD-10 codes occurred in 2015. Therefore, this was the earliest year the data was available to be analyzed. To look into the need for subsequent ankle procedures in patients who either had hardware removed or retained, the initial cohort was pared down to patients who had their index surgery from 2015 to 2017 in order to allow for a total of 4 years of follow-up. Demographic data, including age, sex, race, payer type, predicted income, geography, and fracture type were collected. The overall cohort included about 1,008 patients. The average age was 12.6 years old. The majority of patients were male, white, and privately insured. The average predicted household income was around $47,000 a year. Overall, 24.2% of patients had their hardware removed. Factors associated with hardware removal included younger age, higher predicted household income, and patients with fractures that involved epiphysis, such as Salter-Harris type 3 and 4 fractures. The figure on the left demonstrates the timing of hardware removal for the 24% of patients who had their hardware removed. The average time for hardware removal was about 9 months following the index procedure. The figure on the right shows the rate of subsequent ankle procedures in the cohort with 4 years of follow-up, which demonstrates that there was no statistically significant difference between patients who had hardware removed versus having their hardware retained. The overall rates of subsequent ankle procedure was 3.4 and 3.7 for hardware removed and hardware retained groups, respectively. Our reported data of hardware removal is higher than the rates quoted in literature, but it is the first study looking specifically at injuries involving the ankle physis. Additionally, we reported lower rates than those in the adult population for the distal tibia and fibula. Although causation cannot be elucidated from the current study, some hypotheses for the factors associated with hardware removal include the fact that lower income has been shown to be associated with lower healthcare specialist utilization. In the multivariate analysis, patients with predicted income greater than $75,000 were 3 times as likely to have their hardware removed than patients of lower income. Additionally, higher rates of hardware removal for epiphyseal fractures may be attributed to the fact that these fractures often require more fixation and are more likely to become symptomatic. This paper allows surgeons to counsel patients that retained hardware does not lead to a higher rate of subsequent ankle procedures, with their overall need for subsequent ankle procedures being roughly 3%. Additionally, patients can be counseled that about 1 in 4 patients will have their hardware removed. The overall limitations of the current study are those associated inherent to database studies, like coding errors, incomplete reporting, bias, and confounders. There may be higher rates of hardware removal or subsequent procedures than reported here, given the fact that patients may have followed up at non-participating hospitals or may not have had their hardware removed within the study period. We're not able to specifically look into transitional ankle fractures, and the data only allowed for general descriptions of the type of physeal ankle fracture. The data were not able to provide information regarding the indication for hardware removal either. Finally, additional multi-center studies using pooled radiographic, demographic, and clinical data are needed to validate the rates of hardware removal, identify indications, and better inform surgical recommendations and patient expectations. Thank you.
Thank you so much. I'd like to invite Dr. Jeffrey Kwong to present on correlates and outcomes of goal concordant care, cross-sectional study in the hand and upper extremities.
Thank you for having me. I'm Jeffrey Kwong. I'm one of the PGY2s. I'll be presenting our work on goal concordant care in hand surgery. And I have no disclosures. So high quality care aligns treatment with and is responsive to patients' preferences and values. And goal concurrent care is associated with improved outcomes, better medication adherence, higher patient satisfaction, and the concurrent care has also been proposed as a quality measure by the National Academy of Medicine. Quality measures have also been gaining increased importance with specific attention to patient satisfaction and patient experience. However, in orthopedic surgery, the relationship between goal concordant care and quality measures has not been previously explored. So we asked 2 questions in this study. In the context of hand and upper extremity surgery, is there an association between goal concordant care and patient satisfaction? And what are the factors associated with goal concordant care? To answer this question, we conducted a cross-sectional study of adult patients in the hand and upper extremity clinic. Before the visit, we asked patients to select their top 3 goals from a piloted list, which included surgery, receiving medications, receiving an injection, getting information, getting a brace or splint, or receiving imaging. And this list was developed based upon the most common treatment options from 3 hand surgeons and was piloted with a list of 10 patients to ensure that it was comprehensive. Then after the visit, we asked patients, which of these treatments did you receive? We also asked patients to fill out a couple quality measures. To measure patient satisfaction, we asked them to fill out the Press-Ganey Outpatient Medical Practice Survey, which consists of 10 questions with a Likert scale of 5 responses. Patients are classified as dissatisfied if their score was less than the 33rd percentile, and satisfied if their score was above the 33rd percentile. And this cutoff helps account for the potential ceiling effect of this scoring method and is based on previously published methodology. Patient experience was based on a likelihood to recommend scale from 1 to 5, with a positive patient experience being 5, extremely likely to recommend. And then we also collected information on demographics, including age, sex, income, insurance type, And we assess their health literacy based on a single item screener. How often do you need to have someone help you when reading instructions, pamphlets, or written material from a doctor or pharmacy? And then we assess their English proficiency by asking the US Census English proficiency question, how well do you speak English, with a threshold of less than very well? And we ask them for their preferred language at home and with medical care. So we conducted an a priori power analysis using the likelihood to recommend with an alpha of 5 and power of 80%, and we found that we would need to include 162 patients. We conducted a univariate screen of variables for association, followed by linear logistic regression, and all analyses were conducted in SAS. So we enrolled 169 patients, roughly half male and half female, and we found that goal concordant care was achieved 62% of the time. As you can see in these pie charts, the leading goals included receiving information, scheduling surgery, and receiving imaging. And in terms of leading treatments, receiving information was also one of the key treatments received, as well as imaging or an injection. So now going back to our questions, is there an association between goal concordant care and patient satisfaction or experience? And we found that there was not. Goal concordant care was not associated with either. And we further conducted a sub-analysis to show that satisfaction and experience were not associated with scheduling surgery or receiving injections. We then looked at our next question, what factors are associated with goal concordant care? And we found that discordant care was associated with lower income, with patients who have an annual income less than $50,000 per year with an odds ratio of 3.37 for receiving discordant care. Those who spoke no English at home or who preferred a language other than English were also more likely to receive discordant care. In a multivariate analysis, we demonstrated that lower income remained significantly associated with discordant care, but the language variables were no longer significant in this analysis. And finally, we conducted a stratified analysis by treatment goals, a stratified analysis of treatment goals by income. And we found that those who are wealthier are more likely to desire information. But on the other hand, those who had lower income were more likely to request specific treatments, such as surgery, medication, bracing, or imaging. In sum, we found that concordance was not associated with patient satisfaction or experience. And in particular, injection or booking surgery was also not associated with either of these outcomes. But we did find that lower income and those who preferred their care in a language other than English were more likely to receive discordant care. And specifically, those making less than $50,000 per year had 2 to 3 times the odds of receiving discordant care. And we found that income confounds the association between language and concordance. In a sub-analysis, we found that patients with lower income were more likely to request specific treatments, and this may be a driver of the observed discordance. This may reflect differences in desired treatments that may exist before patients come to clinic. And specifically, patients with lower income may consider the cost of one treatment versus another, the impact of treatment on time off from work, or they may have a lack of education about specific diseases. And for these reasons, patients with lower income may come to clinic set on a specific treatment and find out they may need another. On the other hand, there's a predilection for patients with higher income to want information, and this may reflect a greater ability to get second opinions, as well as more time and means to weigh their treatment options before committing to a particular course of treatment. Overall, our study suggests that income and language-related disparities may perpetuate health inequities and lead to less patient-centered care. And specifically, to mitigate this inequality in concordant care, it may be important to emphasize the use of interpreters and the training of a diverse physician workforce. And future studies will certainly need to investigate the longitudinal impact of wealth and language disparities on concordant care. Thank you so much.
Thank you so much. Now I'd like to invite antibiotic bead pouch versus negative pressure wound therapy for initial management of type 3 open tibia fractures may reduce fracture-related infections or retrospective analysis.
I want to thank the program committee and the Abbott Society for inviting me to present and be with so many mentors and friends in person. It's a privilege. I'm an orthopedic trauma surgeon at University of Southern California. I work at Los Angeles General Medical Center, This work was supported by research funds from Mayo Trauma North America. The other disclosures are not relevant. So the clinical problem I want to chat about is tibial shaft fractures. They're frequent. They're the most frequently fractured long bone. They are frequently open, and ones that are open frequently get infected. About 1 in 4 and 1 in 5 develop a fracture-related infection. We know we can intervene on some modifiable risk factors, like giving antibiotics early, debriding well, and for those that need it, covering the open fracture with soft tissue. But soft tissue coverage is not always immediately available or appropriate for the wound or for that patient, depending on what other injuries they may have. So at the initial debridement, typically some form of temporary dressing is applied. Historically, it was gauze dressings of some kind. Options now include antibiotic bead pouches, negative pressure wound therapy or wound vac, or a combination of the two. For those who have less experience with it, antibiotic bead pouch involves fabricating antibiotic beads out of polymethyl methacrylate cement, putting antibiotics such as vancomycin and tobramycin or cefazolin in it, and typically putting them on some kind of suture and then placing them within a wound. This is a patient I took care of who was run over by a fire truck with a 3B open tibia that needed soft tissue coverage and required multiple debridement procedures until the wound had declared itself and was ready for soft tissue coverage. There's an ankle that's an example too. The beads are sealed into the defect with a semipermeable membrane and then exchanged as needed, often with debridements every few days. The alternative that's commonly in use is negative pressure wound therapy. Many of us have applied many wound vacs involving a reticulated foam dressing that is attached to a suction device, which decreases edema, does improve local blood flow. But we don't fully understand is what the effects of these two alternative treatments for the same problem have on the risk of fracture-related infection. So antibiotic bead pouches have been associated in multiple observational studies with a lower risk of infection, but in comparison to gauze dressings, negative pressure wound therapy, depending on some data, may decrease, not change, or increase the risk of fracture-related infection in the setting of open tibia fractures. And the question here is the use of one versus the other, or the combination of the two, associated with the risk of fracture-related infection. And the objective of this study was to generate pilot data that would support a randomized trial. The design, this is a single center retrospective study, patients 16 years or older with isolated displaced extra-articular tibial shaft fractures with a type 3B Castilla-Anistron open soft tissue injuring that's going to require rotational or free tissue transfer, and had a temporary dressing placed at the initial debridement. And the intervention was antibiotic bead pouch, and the two comparators were negative pressure wound therapy or a combination of a wound vac on top of antibiotic beads. And the outcome was fracture-related infection requiring debridement or amputation. This time period was me looking back at starting in a new center and seeing what had been done, 2007 to 2020. And our median follow-up was 33 months. We contacted patients by telephone to determine the outcome. We used two prospective databases, one our trauma activation registry, and then our plastic surgery colleagues maintain a prospective flap registry as well. And we identified from those 216 open tibia fractures, but some were misclassified or not eligible, and ultimately had 113 3B open tibias that met inclusion criteria. 41 received antibiotic beads, 59 received negative pressure wound therapy, and 13 received a combination. The patients were no different with regard to treatment in terms of age, sex, body mass index, substance abuse habits, and medical comorbidities. Nor were they significantly different by mechanism, the laterality, or the location of their fracture along the tibia. Nor were there treatment differences significantly different with regard to time to receiving antibiotics in minutes, the provisional stabilization that was performed, whether external fixation, internal fixation, or splinting, days from injury to flap, the type of definitive treatment, whether intramedullary nail versus a plate and screw construct, and whether received free tissue transfer, or with regard to follow-up. However, our days from injury to flap is far higher than is recommended and as standard. It's at 13 median, 10 to 13 between groups. There was no significant difference on bivariable analysis in the risk of fracture-related infection requiring debridement or amputation between groups. But mechanistically, it makes sense that applying a negative pressure wound therapy device to an antibiotic bead soup is going to suck out the antibiotics and possibly be clinically less efficacious. So in our analysis, also noting that the univariate risk of infection was somewhat similar between the combined therapy and the negative pressure wound therapy, we compared antibiotic bead pouches to either negative pressure wound therapy with or without antibiotic beads in a multivariable simple logistic regression analysis, and found that there was a lower risk of fracture-related infection and 3B open tibia fractures when antibiotic beads were used versus negative pressure wound therapy with or without beads. And other relevant factors included tobacco use, the location of the fracture along the tibia, the need for free tissue transfer. Oddly, diabetes was protective, and on a closer inspection, our diabetic patients got flaps sooner over the time period than non-diabetic patients, as time to flap improved over time and the number of diabetic patients increased over time. The number of debridement procedures was also associated with a lower risk of infection. So in discussion, the best recent systematic review suggested that antibiotic bead pouches versus negative standard dressings were associated with a substantial absolute risk reduction of 12% for fracture-related infection. Standards trial suggested the negative pressure wound therapy may decrease infection. The Wolf trial found no difference, and there's some observational data that suggests that negative pressure wound therapy may increase the risk of infection, especially if it's left on for too long between the initial debridement and coverage. There are animal models that suggest that negative pressure wound therapy does permit Staph aureus and other bacterial species to grow underneath it if they're not on antibiotics. And that combining negative pressure wound therapy with antibiotic beads does reduce the local antibiotic concentration to below the minimally inhibitory concentration. There was a similar study, the Sparta study. It was 15 centers over a similar time period in 409 patients with a much shorter time to flap, and found that the time to flap mattered a lot in terms of the infection rate. But if you calculate it, that's only 1.5 flaps per center per year, which makes me question some of the inclusion criteria or methods of how that study was done. But bottom line is there's a need for a randomized trial, and these data suggest that there's not insufficient clinical observational data to choose one versus the other. There may be a benefit to antibiotic beads. It needs to be shown in a prospective and randomized fashion. But someone came up with that idea first and is a good friend of mine. And so the beads versus VAC trial has been funded and will be enrolling soon. Thank you.
Thank you so much. And a comment. First, Dr. Patterson, that's a study that's needed to be done and looks at a question that's been out there for 20 years or so when vax came out. I was practicing during that transition where we always used bead pouches and we always looked at vax, and I think we were persuaded by the way the wound looks, whether it happened on an nice granulation tissue, but there's a big concern that it might delay flaps and those sort of things. So I congratulate you on your comments. I agree with them, and I'm glad that a prospective trial has been going. We often use the stage approach where you use a bead pouch immediately and then change to the vac at the second surgery. So that's a comment. But a quick question to Dr. Lee and Dr. Chuko. Did I get that right? Close. So with your studies regarding fracture care in Tanzania, do you see an opportunity for this to actually change the way care is delivered there, or has it already? Kind of plans for disseminating this information you've developed?
Yeah, I think definitely our goal would definitely be to change practice. And I think that's one of the problems is that, historically with global health is that people go in there with their perspectives from other countries and try to tell the local surgeons how to do things. And I think one of the major goals of IGOT and our approach is to develop local sustainable solutions, whether through cost effectiveness analyses or through randomized trials that seek to modify, surgical technique or approach. So there's another study that's being done right now looking at using cost-effective antibiotics that are locally available to reduce fracture-related infection. So I think, there's a very real world that this can help change practice in those countries, and we're trying to do it as a partnership and not as a one-way kind of, relationship.
All right, thank you all. I'd like to thank all the presenters from these first two sessions.